I'm Kieran. I'm one of the fellows over at Glenfield. Come to Glenfield to work in adult ICU for a year, and also as a fellow with the ACOTS transport service, which is part of the regionalisation of transfer services, which we'll talk a little bit about, as guidelines have really suggested that transfer between ITUs should be organised and involve trained services, which also potentially takes a bit of burden off the local ambulance services, emergency ambulance services, and it also takes strain off individual units having to provide staff to go out and do transfers. But it's certainly still an area that people have mixed opinions on, and there's still a lot of evidence coming out, so we can chat a little bit about that. I think perhaps Susan has done a talk on this not too long ago, but if not, Susan Dashy's the lead for ACOTS and would be a good person to direct further specific questions to. I think, oh, can I move my slide? There we go. Can you see my next slide, trainees?
Yeah, that's moved forward.
So I suppose one of the relevances for today is that this is a relevant area for trainees within the Royal College of Anaesthetists curriculum, which everybody can't have missed, has been updated, but it still contains transfer, and that's sort of badged in with resuscitation, and it says within it that one of the larger domains that need to be worked towards is ability to resuscitate and stabilize somebody and then move them safely to somewhere where they're going to get the appropriate level of care. And likewise, the Faculty of Intensive Care Medicine also has the high outcome learning area, or the high-low of identifying and resuscitating and then moving a patient safely to the appropriate place to look after them. And this will be one of the overarching takeaways from this, is possibly some time ago transfer was seen as sort of doing your best, or scooping and running and getting a patient to somewhere where the definitive excellent care is going to happen. It's now very much expected that care during transfer is not inferior to care that will be delivered in the area where the patient is taken from and delivered to. So care needs to be consistently good and to the same standards, which includes intervention and monitoring of that patient. So there are competences in all types of staff's learning curricula. Medical staff, as we've said, have learning outcomes and competences defined in their relevant curriculums. ACCPs are recognised to play an important part in moving patients around. The exact roles ACCPs undertake do continue to vary between clinical environments, and therefore it's not in the actual ACCP curriculum, but there's an acknowledgement that the competencies they will possess will depend on the actual roles they're undertaking, so will be agreed locally. But nursing staff are essential as well to transfer, and there are national nurse leads that provide advice on the competencies that they should have if they're involved in transfer. So thinking about a patient that needs to move, one thing is that the ICS levels of care, so when we talk about a level 1, 2 or 3 patient, that isn't necessarily a helpful way of thinking about moving a patient, although it's often the way we talk about patients. So level 1, 2 or 3 care definitely provides clear communication between us, understanding the level of dependency that that patient probably has. But that level of care doesn't necessarily correspond with the level of risk that moving that patient may have. So if you think of a patient with a tracheostomy 3 weeks into their complex wean that's maybe on continuous positive airway pressure ventilation and is having some renal replacement therapy, that would be a level 3 patient, but they may be quite stable. You may have a patient who's only been in the unit 48 hours on non-invasive ventilation for pneumonia and is pyrexial and is quite unwell. And they may be a level 2/3 patient who would be much less suitable for moving any complex distance. So the point there is that an individual risk assessment needs to be made of the patient that is being considered for transfer, and it needs to be by an experienced clinician and somebody who understands what is going to be involved in the transfer. So we should account for their current clinical condition, and physiology scores are useful for helping with that. You need to consider the specific risks to that patient's condition and what moving the patient in that condition may do, and that involves what stress may be provided by movement of the patient, lack of immediate access to hospital facilities if you're taking them outside of the hospital, and really hard thing to predict. There's no hard and fast way of knowing this, but the likelihood of deterioration during transfer, and I would speculate that that's probably a part of the assessment that becomes more robust or more reliable amongst people who have done a lot of transfers. Consideration of what type of monitoring is necessary. As I said, there's no acceptance that monitoring can be inferior during transfer. So the type of monitoring or intervention that might be needed in the next period of the patient journey needs to be considered. And the mode of transport is important. We're having a bit of a chat at the beginning about types of transport involving air, which we're not going to talk about here, but there will be types of patients, for example, with pneumothoraces and things, that movement in an aircraft that isn't going to be compressed, for example, or based on altitude, could be a whole different proposition to moving somebody by road. So this is the point I was making. There needs to be continuous, seamless critical care. So guidelines are pretty clear that there needs to be a standard of monitoring during the whole journey that is consistent with how the patient was monitored before they left and as they would be expected to be monitored after arrival. So observation needs to be continuous. You need to continually be able to see the cardiac rhythm. There needs to be blood pressure monitoring, saturations and end tidal carbon dioxide for any patient with an airway, and the ability to measure temperature as well. And then many of these patients are likely to require advanced monitoring, and the advice and guidelines around this are that non-invasive blood pressure is accurate, but it does struggle with motion artifact by virtue of how it works. So it can be unreliable in a moving vehicle. And also the practical consideration, it's actually very draining on the battery each time it inflates and deflates. And so invasive blood pressure monitoring is probably preferable in the vast majority of patients. Central venous catheterization is rarely essential, but if it's present, you should be able to continue its monitoring. The advice for a monitor used in transport is that it should be capable of displaying 2 invasive pressure waveforms. Pulmonary catheters are sometimes in situ. It's probably a less common monitoring device, although it may be having a bit of a renaissance in recent times. It's obviously far more common in a cardiac ITU. The key takeaway for this is, don't move somebody with a monitor that you're not likely to need, and certainly one that you're not familiar with using. But if there is a pulmonary artery catheter and it needs to stay, then you either need to see the pulmonary artery pressure trace at all times to avoid injury to the lung by accidental wedging of that into a pulmonary arteriole. And if you can't do that, and I can't see that you would often need those pressures in an ambulance, then if you're going to leave it in, it should be withdrawn into the CVP or right atrium position, so it's well away from causing harm and is just giving you a CVP trace. As said, the standards of monitoring need to be the same as in the intensive care environment, and therefore, as with a ventilator, you're able to measure accurately the inspired oxygen concentrations as well as expired and patient saturation. So on most of the transport monitors that are available, and the only ones we should be using, they should give, the transport ventilators, they should give the inspired oxygen concentration, and capnography is essential. So it's very clear from the National Airway Project 4, which is 2015, some time ago now, that most airway problems were outside of theatre environments, and where they occurred, it was often associated with inadequate monitoring of the airway. So wherever you're doing airways, A&E, radiology, whatever it is, you need to insist on capnography. And that's the important thing about transfers. When we talk about transfers, all of this guidance applies not only to moving somebody between hospitals, and that could be what seems like a short distance between the Royal and Glenfield. It could be a bigger distance between hospitals in totally different regions, but these same standards and guidelines apply to taking somebody for a CT scan. Obviously, we make decisions about, not practically needing to put them on the same trolley that you would take into the back of the ambulance, because that is there for certain safety reasons in an ambulance. But all of the guidelines about standards of monitoring and intervention and what you're going to do if something goes wrong are the same, whether it's within a hospital or between hospitals. So we always need to think about timing and suitability of transfer, and that would apply within a hospital and between hospitals as well. Both thinking about the resources involved. So I suppose if you're going for a CT scan, when can that department reasonably accommodate you? But it also needs to be, when can we reasonably provide the appropriate trained staff to move this patient out of the unit and provide the same quality care in the lift, in the corridor, as they would be getting if they'd stayed in the unit all day. And that's the standard to strive for. Capacity transfers should therefore be agreed between a referring and receiving consultant, as being both necessary, unlikely to compromise that patient's care, and also in conjunction with the network transfer policy. If you're asked to do a care critical transfer or time critical transfer, the guidance is very clear that it shouldn't be delayed while the potential hospital you're going to is waiting for a bed. So if somebody needs decompression of an intracranial bleed, the patient needs to move ASAP, and all measures need to be taken to decide where to look after that patient on arrival, while you're in progress. And that's one reason, or that's one situation where you can see why it's essential that we have spare backup battery power, plenty of oxygen, and the same monitoring that you would expect in any critical care environment, because you may arrive somewhere and need to provide a bit of ongoing monitoring and support before being able to successfully hand over. In that sort of case, you are almost certainly going straight to a theatre environment before a critical care. And to facilitate this, a bit like the sort of Tetris that's been involved during COVID-19, there needs to be a recognition that certain specialties are located in one hospital for a region, and when that regional specialty care is no longer required, there needs to be a reciprocal agreement to take patients back in the form of repatriation in a timely manner, so that there is then space for the next emergency. I think key things to think about in the medical assessment of moving somebody is if a pneumothorax is present or likely, then chest drainage before departure is a good idea where possible, because it's much easier in a hospital than out on the road. If the patient has a drain, then underwater seal drains do work. You just have to be very careful they don't spill over, so they need to be well secured and they need to be kept below the patient at all times. Chest drains should not be clamped during transfer, they need to still work. Venous access is mandatory and can fail, and it's difficult to get IV lines in the best of times, so 2 cannula are recommended as a minimum, or appropriate central access and a cannula, but 2 routes into the venous system before departure. Shocked patients are going to be even less happy being moved about, and so hypervolemia should be corrected before moving. If they are continuing to lose blood, that needs to be identified and controlled, but I suppose, well, one caveat of that is either penetrating trauma or bleeding aneurysm, where you may not be resuscitating them to a normotension, but that needs to be thought about and parameters set before moving. And if you need vasopressors or other vasoactive drugs, they need to be prepared and established and seen to be tolerated before moving wherever possible, and plenty of spare volume taken with you made up, because that's obviously the sort of drug that is complex to make up. You don't want to be making up drugs in the back of an ambulance. They should have drainage, so nasogastric tubes and urinary catheters before moving, and a handover should occur from the referring unit to the receiving unit. As the person doing the transfer, you'll provide a history as you know it. You should know the history, and you will hand over how the transfer went. But the best team to provide the actual full handover to the receiving unit is the team that's been looking after the patient so far. And patients may need some extra reassurance. They may need introduction of sedatives if they've not had any, or even if they've come off them, and they may need extra pain relief and antiemetics, and that's totally appropriate to facilitate a comfortable transfer in patients who aren't totally asleep. One thing to say, I think across all of anaesthesia and critical care, we know there's a lot of evidence for checklists. You get varying opinions on them, but checklists also seem to work in transfer. There's not such big studies in any area of transfer really compared to some parts of critical care and anaesthesia, but there are small studies that in conjunction with what we know about checklists in the rest of our practice suggest that they really should be used. So a relatively small, sorry, I've changed slide. A relatively small study did show that there was significant reduction in physiological deterioration or equipment-related problems using checklists, and similar small study has shown that there's less adverse events through the introduction of checklists into a pre-transfer check system. I think we've said about this. So transport can be within or between hospitals. The standards are the same, there's clear guidance that there need to be systems and resources to resuscitate and stabilize and then move a patient within a hospital as well as between hospitals. And that involves assessment of your high dependency areas, acute wards, emergency departments. Now that doesn't mean that all the equipment needs to be in that location. A key part of the governance of a transport system is the maintenance of equipment and checking that it works, and it may well be more appropriate to have the equipment and things centrally so that it can easily be checked in conjunction with medical physics. But people who are going to emergency departments and so forth to bring patients back to an ITU area need to know where that equipment is, know that it's checked if they're not checking it themselves, who is checking it, and that it works. And be aware that they should be striving for the same standards of monitoring and patient intervention between the A&E and the ITU as the patient would get in ITU. So for governance of a transfer service and what ACOTS has regionally, and then there'll be within hospitals, is there is a nominated lead for transfer for the critical care network, and then each acute hospital should have a nominated lead consultant for critical care transport. And the reason that it's good to set things up regionally like this is if you have a critical care network, we can standardize things, and standardization is good because then everyone is singing off the same hymn sheet, and like checklists, standardization is shown to reduce errors, because if we all have the same monitoring systems and documentation, then people know where to look for information, and it facilitates seamless monitoring of patients between the location they've been collected from and the location they're being taken to. And if you have incompatible things, it adds time delay. So we do on occasion have to change the transducer sets and things for arterial lines and invasive pressure monitoring because different hospitals use different things. So I think that's all I have to say there. A big area is use of suitable ambulances for moving patients between hospitals, and this is probably a big area where training needs to happen for anybody involved. And as you approach asking about and getting experience of inter-hospital transfer, you will want to see the ambulance and have some of these systems explained. The key is that ambulance transfer and moving a patient between ITUs doesn't only put the patient at risk because of the difficulties of maintaining a standard of care, but also the physiological insult of moving a patient who's critically ill. But there is also risk to the medical staff involved in the transfer. And you can see there that Department of Transport stats show that there was a not insignificant number of injuries involving ambulances in the space of a few years. For that, or with that in mind, it's imperative that staff wear seatbelts during transfer. A patient should be stable during transfer. So if we've done all the things we talk about, there shouldn't be need to intervene unless there is an unprecedented emergency whilst moving. And you can write down observations and things from a seated, seatbelted position. If intervention is necessary, therefore, such as cardiac arrest or a new pneumothorax, the team should be briefed prior to departure, and you should know within yourselves that what we're going to do is stop this ambulance in a safe location to provide the intervention that's necessary. If that then fails or is not successful, a decision needs to be made about moving to the closest hospital for ongoing care, even if that wasn't the planned hospital at the point of leaving your pickup location. So other equipment to think about is minimum standards of monitoring are applied in every case. observations need to be maintained. The patient has a 5-point harness. That's the safest way to secure a lying down patient in a fast moving vehicle. And we shouldn't do high speed movement unless it's required. It will be a decision between the clinical team, so the doctor and nurse, but in conjunction with the ambulance, who'll have ultimate responsibility and decision about whether blue lights and things are appropriate. And that will only be for clinical need. All hospitals that are responsible for transferring critically ill patients should have access to a compliant trolley. This is called a BSEN sort of legal requirement for standards of ambulances and transfer equipment. The BS is the British safety standard. C relates to European, and they're the same. Just the letters change depending what you're talking about. And this is the trolley in question. You'll have probably seen it in your units or in the hospitals. What this is it has 4 brake points on the wheels and then can clip into an ambulance fixation points between the wheels, and that trolley is tested to 10 Gs of force, which means that it's very stable. It has secure places for oxygen cylinders. There was a terrible case prior to use of these sorts of trolleys in the Manchester area where somebody sitting behind the driver in an ambulance was killed by a projectile oxygen cylinder. So everything needs to be secure, and by securing all of the pumps and all of the oxygen and monitoring below the patient, it lowers the centre of gravity of the trolley and means that it's as stable as it possibly can be. There needs to be plenty of oxygen for the journey. We take spare oxygen on the trolley, and the ambulance also has oxygen cylinders available. We need to be familiar and have a plan for how we can use ambulance power. So when we get into the ambulance, some transfer groups use a power inverter, others have a conversion. We have a conversion to use a 3-point plug, but it means that we're not relying on batteries for the whole journey, because we may need the battery power if we get stuck in a lift, for example, at either the receiving or departing hospital. So we plug in when we can. We need to be able to see everything and access the patient from the right-hand side. So the patient's left-hand side is against the ambulance wall. The trolley is designed so that we can raise the head of the bed. That's important, obviously, if you're moving somebody with a high intracranial pressure or who needs chest physio en route. And we need to think about the increasing weight of patients and staff safety. Staff have got long careers, they need to be able to work, and musculoskeletal problems are the main reason that people miss work. So ideally there should be a lift to get into ambulances. Not all ambulances have a hydraulic lift, but they do have winches, and these should be used, and staff should be trained to use them. The equipment, as I said, is put below the patient, and the reason for that is to reduce the centre of gravity. It also reduces the chance of equipment coming loose and flying around the ambulance, and all of the things that you may need. So that's monitor, ventilator, plenty of infusion pumps, suction, and other specialist attachments need to be fixed in a fixation that is also tested to 10 G. So we shouldn't be bolting on extra bits and pieces, because that can become dangerous if the ambulance moves suddenly. So there's loads of things to think about in the safety of a transfer, and we also need to think of things like PPE for staff and high-vis equipment for us. So you're likely to enter the hospital through a back entrance. If you have to get out of the ambulance when you're on journey, there's risk from other vehicles and things. So appropriate clothing and things needs to be worn, and you need to be familiar with the type of oxygen cylinder that you're taking. The more sort of high volume BOC white cylinders are increasingly used because they do hold a little bit more, and the sort of small standard one you'll have seen is about 460 litres, one full. So what research has been done in transfer? Well, it's a relatively low research zone compared to other areas of critical care, but some has been done, and they're relatively small studies. There's a bit of interest around the idea that there may be a slightly increased length of stay in patients who are moved between units. And I guess that makes sense. It probably takes a bit of time for the referring consultant to identify and decide that that patient is suitable for moving. And then when they arrive at a new unit, it's going to take a bit of time to get a feel for that patient. And I suppose, that's just the human factors. There is also the risk of loss of recruitment, changes in fluid balance, interruption of immediately essential therapies like renal replacement therapy during the move, and all of these things may just impact, along with increased sedation and things, may all impact the weaning process and length of stay. The evidence for sort of really bad outcomes like more cardiac arrest, more death, is reassuringly not really there. And when we think about dedicated transport teams, there does seem to be some evidence for this, and it may be as simple as, I've just gone through a load of regulations and recommendations that maybe aren't that exciting and maybe don't want to think about every day. So maybe it's as simple as a dedicated transport team is familiar with all of those things and the logistics of transfer and the exact equipment they're using and suitability of who to move, that the outcomes are possibly a little bit better. In the Netherlands, they sort of retrospectively looked back at the use of a mobile intensive care unit and found that there was less adverse events, almost half as many adverse events in a team that was moved by a specialist ITU group that was familiar with transfer. And in fact, when you look within those groups, the Apache scores were higher in the dedicated transport group than the standard transfer group. And there were less airway problems. So there was a bit of evidence there for using a dedicated team. And in a trauma network in Australia, they found that there was less likely to be in hospital mortality if you were moved by their dedicated trauma retrieval service rather than whoever was available. But there's little published evidence relating to disadvantages of specialised transfer teams, and I suppose that's an effect of the research is probably going to be done by people who are interested in a dedicated transport team. But there is discussion about, are there negative effects, and I think this goes back to the beginning of the presentation, talking about how this is clearly within the curriculum of ICM and anaesthesia trainees. If you have a dedicated transport team, do you take away transport training and familiarity from people who used to do it, which would have been available staff on ITU? And sometimes when the dedicated transport team isn't available, you're going to have to use those people in a time critical situation, and it's not good if they've had no transport experience. So I think that doesn't mean you shouldn't have a dedicated team. I think what it means is the dedicated team needs to take an active role in training and maintaining skills of people who don't get to do a lot of transfer, and be open to taking people on observational transfers, I would suggest. So I think in summary, we just need to think that every transfer does need to be justified. There's a risk to the patient who's being moved. It could be distressing for relatives who definitely need to be informed of when and why their loved one is moving, and there is a risk to staff. The standard of monitoring and all care is expected to be the same between units as it is in the units. There are guidelines to be familiar with that are sort of produced and accepted by the ICS and FICM and Association of Anaesthetists. There are training requirements to be aware of, and there are courses available, and it's recommended to go on a transfer course, but unfortunately in recent times I think a lot of these things have suffered because of COVID-19. So thanks for listening. I hope that was of some use. I'm happy to answer any questions or talk through any cases or situations that you'd like to.
Kieran, that was brilliant. Thank you very much for that. If people have got questions, please by all means pop your hands up. I think I've probably got a few questions, Kieran, if that's all right.
Okay.
I mean, if you had sort of one tip for people for transporting patients, what do you think it would be?
I think I would say, or I think it's definitely an area where people, I feel, keep ideas to themselves. I've always been surprised at, if I ask just before we go, does anybody have any concerns about this transport or moving this patient? When directly asked, people will say that they do have concerns, whereas they've sort of kept quiet and gone along with it prior to that. So if I've said, look, I'm not happy with this blood pressure and I want to wait until we've sorted it, people then tend to say, I'm glad we sorted that before we left. And so I think it's important to empower people around you to say what their concerns may be, because they can be a valuable source of concerns, but may just feel shy about raising them.
Okay, that's really interesting. Actually, it's worrying that you could be sort of potentially almost out the door before somebody raises their very valid concern, really. Yeah. So do you think you approach like intra-hospital transfers any different to inter-hospital transfers?
I think historically, and by historically I would say even in the recent history of my recent current training, we have done, and I think it's very apparent that we shouldn't do.
Right.
So I think what we need to think and spread is to be in the mindset that it wouldn't be acceptable that the chance of recovering from a cardiac arrest in CT scanner is less than if somebody arrested in the unit, whereas we should be striving for the outcomes to be equal. And part of that is to not take someone to CT who could be expected to arrest in the scanner. So there's a whole thing around that of selecting patients and choosing appropriateness, but that it comes down to making sure the patient is monitored appropriately and in the same way they were in the unit, and transferred to CT and back by people who are comfortable with anticipating deterioration, totally familiar with the patient, and are happy to deal with the consequences. And then when you consider training, that doesn't mean that junior people shouldn't go, but there's certainly audit data in the recent past of incredibly junior people doing transfers by themselves, and by that I mean taking people to CT or around the hospital. So I think we need to help people gain experience, but recognise sources of help. And that might not mean, you know, I'm not sort of advocating total consultant presence or even senior registrar presence. It may be that, you know, in the phase of someone's development, you say, well, you go to scanner, but this registrar knows all about the situation, and this is their phone number, and they've definitely got reception, and they're immediately available, or they're going to pop down and check in the middle of it, or something like that.
I think that makes a lot of sense. I mean, I certainly, you know, as a trainee, I always found transfers quite sort of anxiety sort of driving, really. It was always, you're leaving what very much felt like a place of safety to, you know, even if it was just to, you know, a couple of floors down or wherever to the CT scanner, it was always a bit, you know, out of your comfort zone. You've not got all the help there that you're kind of used to, really. And then certainly, yeah, going in the back of an ambulance was always okay. Let's make sure everything's kind of sorted before we went. But yeah, apart from the transfer course, there wasn't a lot in the way of education, really. A lot of it was get on and do it, and if there were any problems, sort of learn from that, which is not necessarily the best way to do it, I suppose. Are there any examples of where you think, I mean, sort of in your sort of experience, where you think you'd have done things differently, or sort of any important lessons you've learned along the way?
I think some of the basics. So I think, you know, calculating possible oxygen requirements. You should always, you know, the advice is to always take double what is required. I not in this trust, but I once was in a lift that broke, and they do break. You know, NHS hospitals are. Some bits are new, some bits are very old, and you know, when a lift breaks, the patient might be totally stable, but you very quickly focus in on what am I going to do about oxygen here. It's useful to know that ventilators like the Oxylog 3000, the orange and white one that most of us use, although there are others, and I think we'll get others, but they do show you the oxygen consumption, and people should be aware that oxygen is also used to mechanically drive the ventilator as well as what is being consumed by the patient. So it will tell you on there how many litres per minute is being used. I think that's the. I think that's the. I suppose the biggest thing is it can often feel rushed, or you can feel the pressure to get on and do things, and that definitely exists. And it's probably like anaesthetics or many areas of practice. You don't want to be the person who unnecessarily delays and checks and rechecks, and because the longer you faff about, you're going to cross a line into where you're causing more harm than good. But equally, it's about having the confidence, which I think comes from experience, but also knowing that you've been trained and you know what you're doing, to say, you know, I'm not happy to leave yet. I want to sort this and this out, and then we'll leave. And doing that in a reasonable time frame, you know, yeah. I think early on in your experience, it's easy to feel rushed and then do a suboptimal transfer and potentially regret that.
I think it's a great point, really. I think that sort of having I think it's not easy to say, you know, let's just stop for a minute. Actually, I just want to check this out, when, you know, you often got pressure from a lot of different people. You know, the nurses might be putting pressure on you, CT are there, porters are there. You feel a lot of push to kind of get going, really. But I think that's a really important point. If you're not happy, you're the one that's going to have to deal with that, you know, 20 minutes down the line, when you're sort of in a place not of safety anymore, I suppose. Any other questions from anybody else? Otherwise, we'll probably just about draw it to a close, really. If you've got questions, please put up a hand. Jenny, yes, Jenny, go for it.
Can you hear me?
Yeah.
Not questions really, but comments. Just to echo the importance of stopping, even if you're nearly there. even if you're just outside the emergency department, if you need to do something to your patient. I got a needle stick injury from somebody with hepatitis trying to decompress a pneumothorax literally outside QMC by the traffic lights that people will remember if they've been up there. And I should have stopped the ambulance. I didn't. I thought it'd be all right, and it wasn't. Similarly, making sure that you know your kit and you know how to change the batteries yourself as well, because I've run out of batteries partway down a road and then to scrabble around. So tales of misadventure. And also, I don't know whether Dr. Tate's on this call, but also recognising when actually, like you said, it's really, really hard once everybody's there and you're all set to actually say, no, stop, we can't move. It's not the right time. But we had planned a trip outside for a patient relatively recently, and she spotted the patient wasn't well, and we didn't go, and it was good because it would have been a disaster instead of a really nice opportunity for the patient. So don't get caught up in the need to move, particularly if it's for a nice thing rather than a time critical transfer. Sometimes stopping's the hardest thing to do.
Yeah, no, that's fantastic story and point. I think it's not just in transport, is it? It's across critical care and anaesthetics. There's unfortunately countless examples of where a situation sort of gains momentum, and unfortunately the transfer is often the last step in that, where momentum is gained and the expectation is that this is going to happen. It's already been decided, and if you stop it, you're just going to get in the way of it. And you know, that could be a theatre case or anything, and it is hard to recognise, but I think we have to sort of trust our instincts and training to say something isn't right here and we need to pause again.
If you want feedback, please by all means give us feedback, and you get a certificate for your appraisal or ARCP purposes. Please scan the code on here. But Kieran, that's been fantastic. Thank you so much for doing that talk. It's been really interesting on a topic that, yeah, I certainly find it still makes me a bit anxious sending patients off the unit, and you know, if there was a way to avoid it, I'm sure we would, but we don't have the choice often, and it's important that we do it as safely as possible, really. Thanks
for listening. Thanks.
No, it's been great. Okay, so